lipoprotein disease, we have different categorization. The first of all, we can classify them as a two, primary and secondary hyperlipidemia. Primary hyperlipoproteinemia or hyperlipidemia, it means we have a problem in those genes, they are related to metabolism of these lipoproteins. Exactly is related to metabolism of lipid themselves. And also we have a secondary hyperlipoproteinemia, which means another condition like diabetes, like obesity, like actually hormonal change. They lead to the change in the lipid concentration. So they are known as a secondary hyperlipoprotein. So related to first classes, which known as a hyperlipoproteinemia primary, we have a Fredrickson categorization or classification, which you will learn and actually study more and more in the next semester again. The Fredrickson classification classify these to the 5 classes, okay? Actually to the 5 classes, but there are 6 groups, okay? Which some of them are more important, and just I focus on this group. One of these classes known as a familial chylomicronemia or FCS, familial chylomicronemia or familial actually hyperlipoproteinemia type 1. It can be occurred due to the mutation in lipoprotein lipase itself or ApoC2. What is the output? The output is increasing in chylomicron.
Because it doesn't get digested.
Because we cannot digest. We have a family of this beta lipoproteinemia. This beta lipoproteinemia, it's due to the mutation in ApoE. And ApoE was important in uptaking of
VLDL
remnant and chylomicron remnant. Okay? So increase both chylomicron and VLDL remnant. We have a family of defective of ApoB. We have mutation in ApoB100. When we have a mutation in B100,
LDL.
we have increasing in LDL. And also we have a familial hypercholesterolemia. Familial hypercholesterolemia is due to the mutation in
Receptors of
LDL receptor. Because we have mutation in LDL receptor, again we have increasing in LDL.
So if we have the LDL receptor malfunction or mutation, that means there's a problem in the cells in the liver and all the cells?
Just the receptors.
I mean,
for related to LDL, it's just uptake by ApoB100. Okay? If we have a deficiency or defective in ApoB100, they cannot take it. If we have a deficiency or abnormality in LDL receptor, again we can't uptake it. So there is a two reason. Maybe due to the ApoB mutation, maybe due to the LDL receptor mutation. Both of them lead to the we cannot uptake LDL,
so
and LDL is increasing the plasma. Here is the Fredrickson classification of hyperlipoproteinemia. Okay, chylomicron type 1 is increased, type 2 LDL is increased to A, to B LDL and VLDL, type 3 chylomicron and VLDL remnant, type 4 VLDL, type 5 chylomicron and VLDL. Can you classify based on previous? Type 1 is known as a what?
familial
Familial
chylomicronemia.
micronis
Familial chylomicronemia.
Chylomicronemia.
Okay. Familial chylomicronemia is type 1. Actually, S is for single. Familial chylomicronemia single. Doesn't matter if you mention single or large. So, in type 1 lipoprotein, chylomicron is increased. The other doesn't matter. Okay, you can study, and you have to study in the next semester. But for this time, if you know just the type 1 chylomicron is increased and known as a FCS, and we have a deficiency or actually defects in LPL or ApoC2. Type 2A, LDL is increased. As you learn, increasing in LDL is due to two reasons. Defective in LDL receptor, defective in ApoB100. We have two classes of these. Familial hypercholesterolemia, familial dysbeta-lipoproteinemia. And also related to remnant, type 3, which is known as a chylomicron and VLDL remnant. The deficiency of or defect or mutation in what leads to the increasing in these two? ApoB. ApoB. So they are more important for your exam. And if you love, you can study all of them. They are secondary hyperlipidemia, the main one. Again, you don't need to memorize all of them. Okay? Just some of them, like hypothyroidism, severe liver disease, actually, obesity, diabetes type 2, they lead to the secondary. In the secondary, we can classify based on increasing or decreasing LDL, elevating or reduction in HDL, or VLDL, and also chylomicron. Okay? All of them known as a secondary hyperlipidemia. But diabetes, obesity, and liver dysfunction are so important. But you as a medical doctor, inshallah, in the actually future years, when you are going to prescribe lab test for a patient, you should know about the lipid profile panel, what they are. What do you need to know about the lipids? So we have a different factors or actually criteria in lipid risk factor or lipid panel. One of them known as LDL cholesterol. In actually lab test, we write LDLC. LDLC means LDL cholesterol. I don't have a marker. I have one of the student brings marker for me. They are here. LDLC, we write like that, which is so important in lipid profile panel. In addition to LDLC, we have an HDLC. And also we have a TC. TC means total cholesterol. TG means triglyceride. So these four known as a lipid profile. TC, total cholesterol, and TG, triglyceride. So, in addition to these four, these days, we can measure lipoprotein remnant. We can measure lipoprotein A, which another kind of lipoprotein specific for heart disease is so important. We can measure the small LDL particle and also apolipoprotein B and apolipoprotein A1. But they are so specific tests, and just a few number of center in the actually some city they can measure these tests in a very specific hospital and for a specific test. But routinely, 90% of the time, we measure these four. So these four give us what? Triglyceride, it's actually clear. Give us the amount of triglyceride. But these three, they are related to the cholesterol amount. One of them, known as HDL cholesterol, which is good cholesterol for us, we should know about it should be higher than this amount. Higher than the 50, 60, actually 40, like that. LDL should be lower than this amount. And if the higher than 100 milligram per deciliter, it means has the high risk for atherosclerosis. And also total cholesterol contain of VLDL
Is the lipid profile only these four, or is it all of those which you
These four. When we talk about lipid profile, actually, you as a medical doctor, in 90% of the actually condition and times, you just evaluate these four. But sometimes for a specific patient, cardiologists and actually endocrinologists, sometimes they may be prescribed these kind of tests. But it's not good. If you become a specialist, you will learn which one should be actually prescribed by you. So related to LDL, we have a committee or actually organization which is known as the National Cholesterol Education Program, NCEP. This NCEP said LDL cholesterol is the primary target for treatment of hyperlipidemia. If you have any patient with hyperlipidemia, you should target LDL cholesterol. You should manage LDL cholesterol. If the LDL managed, there is no any problem related to others. So LDL is a target. So what is the target of LDL? Target should be less than 100 milligram per deciliter. Also, we have some other index like millimole per liter. They can be converted together, doesn't matter. There is a lot of site when you are going to convert one actually factors with one index to another index, just you can search it and convert it, okay? So less than 100 is the optimal LDL cholesterol and corresponding to the lowest level of high risk of actually atherosclerosis or heart disease. But it's not meaning the risk is zero, but it's the lowest level. Between 100 and 129, near to optimal level, 130 to 160, borderline, high level, 160 to 90, high LDL, and more than 190 or 200 has the highest risk for heart disease. And it should be immediately actually take medicine or treatment to decrease this LDL amount. So we have some risk factor, especially Iraqi boys, guys. One of them is what? I'm just looking at cigarette. Yes, cigarette smoking. Cigarette smoking is one of the positive risk factor for heart disease. And unfortunately, as I find out, most of these, not you actually Indian guys, they don't use cigarette too much, but Iraqi guys, they use a lot.
I don't smoke.
Maybe you not a smoke, yes.
Don't care, Jaffa.
I'm not sure about you, I'm not sure about Hassanin, I'm not sure. But about Jaffa, I can say yes, he don't use cigarette. It's completely clear. Doesn't matter, it's not my business, but related to the actually biochemistry. You should know is one of the risk factor for heart disease. In addition to the age, for male more than 45, for female what? More than 55, 45. Female always live longer than that. For this reason, actually they are 10 years after the man, the risk factor is started. Family history is so important. If someone has a family history of actually chronic heart disease, myocardial infarctus, we use different terms. You should know all of them. MI means myocardial infarction. CHD means coronary heart disease. CAD, coronary artery disease. CVD, cardiovascular disease. There are a lot, just there are a few of them, okay? But all the same, they have a similarity, they have a little differences, which you will learn them in the future. And hypertension, blood pressure, more than 140 systolic and 90 diastolic is another actually risk factors. And low HDL cholesterol, less than 40, is another positive. The negative or protective risk factor is high level of HDL. High level of HDL is a negative risk factor.
Does HDL turn into CETB?
Yes. One of them actually. HDL overall lead to the. So let's talk about that. Sometimes we don't have a kit for measure directly LDL, but we can calculate LDL. Okay, if you don't have a kit for measurement of LDL, you can calculate LDL by this formula, which is known as a Fried-Wald form equation of formula. What it says, Fried-Wald? Fried-Wald says total cholesterol. Total cholesterol is equal to what? Total cholesterol. It means the whole content of cholesterol in the plasma.
LDL.
What?
LDL
HDL cholesterol
plus LDL
LDL cholesterol
plus
VDL.
VLDL cholesterol. Okay?
What about IDL?
VLDL cholesterol, IDL, doesn't matter. They are similar. So we can measure total cholesterol. We can measure HDL. What about VLDL? After measuring a lot of actually sample, they find out the VLDL can be actually somehow explained, right, divided by 5. Triglyceride concentration divided by 5 give you VLDL cholesterol. So if you are going to calculate LDL cholesterol, LDL is equal to the what?
Total
Total
cholesterol
cholesterol minus
HDL
HDL
cholesterol.
plus HDL cholesterol plus triglyceride divided by 5. Sometimes they use 0.2 multiply triglyceride. They are equal, doesn't matter. So, today we are going to measure LDL cholesterol and HDL cholesterol, but we don't have kits for total cholesterol and triglyceride, and we don't have time to measure that. But if we have, or in the future you have, you can measure LDL directly and also measure by Fried-Wald. They should be similar. But for those people, triglyceride is high, this formula cannot be used. Triglyceride more than 400 milligram per deciliter, the Fried-Wald equation is not correct. So just to the critical level of triglyceride, the Fried-Wald equation can be used. After that, cannot be used. Related to total cholesterol, the desirable concentration is less than 200 milligram per deciliter. The desirable is less than 200. 200 to 240 is borderline, more than 240 is high. So why I give you this number? Because sometimes maybe you go to your home, they give you the lab result and you don't know. If you look at this, you can find out the cholesterol is high or low, is desirable or no, what is the amount. You should know this.
But if someone, for example, their total cholesterol is more than 240, But the LDL cholesterol is less than 100. Does that mean they have too much HDL cholesterol?
Not completely. If you measure the HDL, yeah, maybe it's because of HDL is high.
So it means it's good.
But, you know, overall, HDL cannot be higher than 60 or 70 all the time for all people. It's not accurate in anyone to HDL be higher than 60 or 70. You know, there is another research, VLDL cholesterol also is high.
If VLDL is high, is that like LDL being high or HDL being
Exactly. When VLDL is high, LDL is high because LDL is synthesized from VLDL. They have a
Same pathway? Same.
direction, same direction. Those reasons, those causes of HDL cholesterol decreasing, they are reason for increasing triglyceride. What they are? Elevated serum triglyceride, overweight or obesity, physical inactivity, cigarette smoking, again, very high carbohydrate intake. If you look at them, we have most of them, okay? Especially this type, very high carbohydrate intake. And especially this time, because the price of meat and protein is too high, we decrease the amount of protein in our diet. And if the carbohydrate increase more than 60% is the highest risk for increasing triglyceride content and decreasing the HDL. Type 2 diabetes, some drug like beta blocker, steroid, and actually progesterone, and maybe genetic factors. Related to triglyceride, exactly like cholesterol. Less than 200 is normal, 200 to actually near to 400 is borderline, 400 to 1000 is high, or maybe it's start as known as a critical level of triglyceride, and more than 1000 is known as a very high triglyceride. And actually maybe sometimes the triglyceride increase maybe more than 10,000 times. It's happened in some patients. So, and if you look at the serum completely, you can see the completely contain lipids. So, for cholesterol, we cannot see the amount more than 300, 400. But for triglyceride, maybe to 1000 to 2000 and more also, there are concentration of triglyceride. And then those actually causes again lead to the increasing serum triglyceride. Physical inactivity, obesity, cigarette, alcoholic use or abuse people, very high carbohydrate diet, type 2 diabetes, certain drug, and genetic factors. So, we have a term known as autogenic dyslipidemia. Changing in lipids concentration known as a dyslipidemia, which dyslipidemia is one of the main reasons of metabolic syndrome. Okay? And dyslipidemia known as these three factors: elevated triglycerides, elevated LDL, and reducing HDL. They are known as autogenic dyslipidemia. 10 minutes. Just 10 minutes rest, then at 11 you come back to the class.